Okay. And the purpose of this session is to demo and validate future state workflow in Cerner and to provide SMEs the opportunity to identify any gaps. Okay, ambulatory refusal inbox. So the provider has the option to sign or refuse any orders, results, or documentation from their message center. This can happen if results are sent to the incorrect provider due to, for example, similar names. And when a provider refuses an order or result, they can opt to select the clinic refusal inbox. And this will allow the clinic to review the refusal, to investigate the cause, and remediate appropriately. So it's very important that someone in the clinic actually monitors the inbox so things don't get missed. So we're just wondering who should this responsibility fall on?
Tommy, just wanted to
Yep.
provide context for the plastics clinic. They did decide that this would fall to the clerk,
Yes.
the clerk assigned to that clinic, so that if there was a need to reach out to anyone, the clerk could do so, not to be the end user that fixes the error, but that investigates.
Mm-hmm.
So this is different than the inbox that's a request for a consult.
Correct. Yeah. A referral that comes to your clinic would get faxed as a document to your queue or land in a request list for booking an appointment. These refusals land in message center as a notification for investigating.
These are coming from the emergency department.
Anything that's refused.
Or in the hospital.
Yeah, it has to originate.
Oh, I see.
Like the idea is that whatever the result is that's been incorrectly CC'd to someone usually originates from this clinic location, and then they're sending it back to the clinic saying we shouldn't have received this.
So the clerk in the clinic gets a referral. They send it to me. I think it shouldn't come to our clinic. I send a refusal back, and you want to clarify who's going to get that refusal. It wouldn't necessarily go back to the person sending the referral. You're saying plastics is sending that back to the plastics clerk.
Sorry, this is before any of the clinic workflow begins. This is sort of an aside before Tommy starts any demonstration. This is simply in case there is something that happens at some point in the clinical workflow where you've sent a result to a physician and they think it shouldn't be sent to them. It's a result, it's not a referral. It's just, say, a pathology report or a lab notification, something like that. And at that point, that physician says, I shouldn't have received this. And then they send it back to the clinic as an FYI to the clinic to say, I don't know where this needs to go. It's a bit of a catch-all, and it's not widely used. We've not seen many refusal inbox notifications in many of our clinics. So this is sort of, we need someone to have to assign to this, but we don't typically see a lot of volume here.
No, that's good, because I'm just wondering if, yeah, any information comes in that's even outside a clinic patient, or anyways. Yeah, so if that works from the clerk's point of view, that's okay. I guess I tend to try to find out who should get it and redirect it myself, but sometimes that won't be possible. I won't know. So what's the clerk going to do with this from that point on?
It would really depend. So they could look at the chart. They could see when the order was ordered and the physician that ordered it. They can look at the context of care, which encounter that order was placed on. That kind of review can happen. And then if they feel like they need to contact the physician who ordered it, they can reach out to that physician directly. Or if it was refused in error to the clinic, they can say, this didn't originate from us, and send it back to the person who notified them. But we have we'll be giving teaching as needed to that workflow to the clerk.
Yeah, so basically we just need someone to review it and then to redirect the incorrect result or letter.
Yeah, a plan of it going back to our clerk makes sense to me, Jeff.
Okay.
I think going back to the clerk is okay, but if it's an important result that needs to be seen by a physician, I don't know medically, legally where we fall if it's gone back to a clerk who is not fully aware of the context or severity. Like I'm thinking if there was like a positive pathology report that somehow came to us, like there needs to be some sort of accountability. So if we do that, it can't just disappear. There has to be some sort of resolution. So I guess it should go to the clerk, but with a caveat that if the clerk's not able to find a resolution, they need to approach somebody about it.
And then would it be the person who just refused it? Because technically,
Yeah,
they're not involved.
well,
But
I mean,
they would only received this if we refused it, right? So
yeah, like
The only-
if we've refused it, then there needs to be some sort of context. So
Yeah.
if the clerk is unclear on what to do with it, then as Pierre says, I think going back to the person who's refused it to help them establish some context and a plan for what to do with that result.
Yeah, that makes sense. And usually if you, Dr. Gee or Dr. Potter or anybody else on that ortho team is going to refuse something, you wouldn't necessarily refuse to this clinic inbox. You'd probably refuse to the physician who sent something to you directly if it came to your message center. Similarly, yeah, we wouldn't expect the clerk to always know exactly what to do. I think that's totally fair.
So how does that work? Because when I go in my message center and I refuse something, I have to redirect it for somebody to review or to sign. Like is there a default that's going to come in that little window that's going to be the clinic clerk? Or?
It won't default to this clinic. It's only if somebody searches VGH orthopedic trauma and chooses that as the forward at their point of refusal that it will come to this inbox, which is why we're not likely to see many.
Okay, I'm not completely clear now then.
Yeah, so I guess normally it would be refused to whoever sent the incorrect result. So it's not very common that you would refuse it to this inbox because it would just go back to the original provider.
Yeah, so how do I refuse it and send it to this inbox? I guess is my question.
Yeah, so you can type in VGH orthopedic trauma and then it will come in here.
Oh, okay.
Yeah.
Someone have to search the clinic to find it,
Yeah.
to send it to the clinic as an entity,
Yeah.
as opposed to the physician that sent it to them.
Okay.
I guess it's for like non-important letter or results that you want someone to investigate. You can send it to this inbox.
Okay.
And then Cherry would do her investigation and then, reach out to the appropriate person.
Okay, that's clear. Thanks.
Okay, thank you. Okay, so our encounter strategy. So I think last time we decided on using the recurring encounter with our multi-phase power plan for all the visits, including those consecutive and extended ones. Just be aware that the follow-up visits must happen within 6 months of previous visits.
And then I just filled in Dr. Potter about our decision to go monthly after 6 weeks. That way we're still within the 28 days of what operationally have been accepted as
Perfect.
Yeah.
Okay, thank you. All right, next. Okay, so when a provider places a referral to outpatient VGH ortho trauma order, a pop-up will happen. So we just want to confirm with you the reference text and also the special instruction that is appropriate for the clinic.
So Jeff, this is another point we discussed. Remember how we wanted to have the...
Yeah, we wanted it to be a mandatory field.
Yeah, so now they can't really, but they can put big red bold things and add a second thing about special instructions. So they can't be the requested provider cannot be a mandatory thing, but this is best they can do is to put the big red thing here, and then in the actual order, it comes up as the special instructions that they have to call us. Because then they'll enter Jeff Potter.
Yeah, correct.
There are 2 flags here that.
Yeah, I mean, there is a field, I don't think we see it there, but there is a field that specifies the provider.
Yeah, they just can't make it mandatory.
It just can't make it mandatory. Yeah, that's
Yeah.
fine. I think, Pierre, we just have to be alert to this, and if we're getting a bunch that don't have a specified provider, then we need to speak to the emergency physicians.
But then we need to do that now already because it's happening. but that's without having this flag. So give it a shot.
Okay.
Have you been noticing? Because I've been noticing that. But there's no documented person that's.
Yeah, I've definitely noticed it. I sent anyways, it doesn't matter. Yeah.
Yeah, so hopefully with this, it'll actually make it better for you guys.
Yep.
Okay, and you're okay with the reference text? Looks pretty okay.
To avoid delays, rejection, please call the orthopedic provider. Say orthopedic trauma provider.
Okay, orthopedic trauma. Okay, we'll add that.
Yeah, orthopedic trauma surgeon. I know this whole debate in the U.S. about providers and things.
Yep, we
there's
can
no
do that.
there's no NPs or PAs or anybody taking call for us.
Okay. All right, perfect. Thank you. And it's just the end-to-end workflow. So for your clinic, you have 3 streams of referrals. The first one is internal referrals from the ED. So those referrals will land on the request list. And then the clerk just go in to the scheduling book the appointment, and kind of recreate a pre-recurring counter. So I can show that to you. Okay. So what Cherry needs to do is to go to this request list inquiry. And then find the location, the clinic, and just click find. And then she can look for these order location that's under ED. So for example, UBC emergency, and then the order is referral to outpatient, VGH ortho trauma. So this is a new order. So she just has to right click, complete the request. And then because there's already a referral in Cerner, so a lot of the information are pre-filled. So I'm just going to send the referring provider. Interpreter requires is gonna be a no, and that's all she has to do. And just go okay. And she can drag it to the appropriate provider and time. And then just go through the process. We're gonna confirm the appointment. Yeah.
Go back to that.
Go back. Okay.
There was no category there for like the requested provider. There was a category for requesting provider, for referring provider, but there's no category for who they've requested. So how does Cherry know which person to drop that?
Let me go back to here. Okay. So it's under here. So she should be able to see it. Like right there. If it's pre-filled by the ED provider.
And if you're hoping for the clerk to highlight scenarios where you're getting them from ED without that field filled out, it's this is sortable by clicking on the header. So the clerk could quickly identify those to let you guys know.
Yeah. Okay, so I'll just go back to complete a request. Okay. So this is where Cherry wants to flip the referring encounter to recurring encounter. So she will go to set encounter, and then she will add an encounter. Pre-register outpatient, and just go through the motion.
We're getting some pop-ups here because the names are too similar.
Yeah.
But
Well, what's the ED test maple? Okay.
just say cancel there, I think.
And so it's fine?
Mm-hmm.
Okay.
It looks like this test patient has missing mandatory data. We can just put some test data here or try a different patient, Tommy. It's up to you, but
Let's see if that works.
the important thing to note is that because patients are all copied over from PCIS and other systems, if they have any encounters at all, they'll be complete in that EMPI.
Yeah, so you shouldn't have to go through that. So the encounter information, we just need to update that to pre-recurring. Medical service would be ortho trauma. Okay. And I'll go ahead, and then it'll remind you anything that you forget. Okay, now the encounter is a recurring encounter, so we can go ahead, just click OK. And then it's booked. Okay.
It looks like a lot of work for Sherry for one appointment.
It is it is quite a bit of quite a few number of clicks. Yeah.
Go ahead.
Looking for the ortho trauma clinic, and maybe plastics or hand or something. But could there be like a limited number? I don't know. I don't share your thoughts. It looks like there's lots of things to enter. Dr. Potter's like 50 people this morning. That's a lot of work for each.
One of the key steps that we didn't really highlight is that the encounter creation process, if it's a recurring, happens for the first appointment and doesn't happen for subsequent appointments on that visit. So that step where we filled out the encounter information, chose the recurring, chose the service, that happens only once, and then otherwise you can just schedule additional appointments to that same encounter.
Yeah, so it's only for the very first time that you kind of have to go through this. For subsequent visit, it's much easier because most of the information is already in there. Like your follow-up visits would be a lot simpler. Okay, going back to our slides. Okay, so our next stream is internal referral. However, this time is a non-ED. So the referral still lands on the request list, and the clerk will have to find those non-ED referrals and then print out the relevant supporting documents and then give it to the MOA and the provider to screen. And then the provider will write on a piece of paper, accept it or reject it, like how you're doing now, give it back to the clerk, and the clerk would book the appointment and create a new pre-recurring encounter like we just did. So to sort out those non-ED referrals, what Cherry can do is to go back to the request list, and she'll just sort it by location. So any location that is not the clinic, the VGH ortho trauma clinic, emergency, or inpatient, those will require screening. And then she just select the patient, and there's a power chart icon. You can just launch power chart right from here and print off any consult note or anything that's relevant that can support you guys triaging. Any question?
That reflects the discussion we had before, so.
Yeah, so basically you just need to locate the documentation and print those out for non-ED referrals that needs screening.
Similarly, just because you're not filling out that accept order to set the urgency of the visit, anything you write on the paper would need to indicate when they should be first seen, just so that the clerk has that detail.
And after that, the booking process would be the same as booking those ED ones.
So yeah, it'll be good to clarify that with the surgeons, like say yes, no, and then how soon, so to speak.
Yeah. Okay. Okay, next is our external referrals. So those community referrals, they land on our QM. Cherry would print those referral out, index the referral package, create a referral encounter, and set the status to ready to screen. And Cherry would then give you those on paper to screen, and same, you would write on a piece of paper, accepted or rejected with scheduling priority, and then give it back to Cherry. She will update the status to accepted or rejected. She would then direct book the appointment from scratch because the appointment, it didn't come from within Cerner, so she has to enter more information. And then she would then modify the referral encounter to a pre-recurring encounter. And if there's any rejected order, the MOA would discharge, will communicate those rejected referrals to the referring provider and discharge the rejected referral. Question? Okay.
No, that works, thanks.
Okay. So I'm just gonna show you something here. Okay. So we'll just pretend a referral package has been indexed and a referral encounter created. So this is what Cherry will see ready for, you won't see the, yeah, so most of the time it will say ready for screening, and then she'll give you the paper, and then you return her back the paper, and then she can update this to accept it. So she'll go to referral management. And then she will go to the referral info and then change the status to accepted. Do not print. And then you update to accepted. And then she would then go to the scheduling book to direct book the patient by putting the patient name, the location, scheduling priority, and then book it. Any question? No? Okay.
I guess these questions are more for Cherry than for us, because
It's more
they're
for
like,
Cherry, yes.
yeah,
Any question,
this is
Cherry?
not.
Does that mean every time we print out a referral for the doctors to check, and they check it over for us to update onto that the referrals are ready to like book in? Does that mean we have to rescan all the referrals back into Is that?
No, everything's already indexed into the power chart.
Okay, so we just print out the referral
Yes.
and then we'll just update it when they give us
Yeah.
the referral back. Okay.
Yes, yeah.
And you can print a copy in the work queue before you index it. So you can print a copy and then index the document to your counter, and then they'll be in both places already.
Yeah, so before you index the document, there's like a print icon where you can just print all the documents.
Okay.
Yeah. Okay. All right. Okay, so next is prior to clinic day preparation, where the provider review the chart. And just, I don't know how you guys, whether you write on a piece of paper appointments that require rescheduling, or what is your current process. You can continue, that is not a problem.
But how would that work? Because right now, let's say I'm in, could we just go through the normal flow? But they don't require appointment, what that looked like. So Sherry has created a list of patients in my clinic, let's say next week.
Yep.
And I'm going through the
Okay,
charts.
so
and then she will have put them already in.
Yeah, so you will be going to your ambulatory organizer over here, and then just find your name. Here I have both you and Dr. Potter. You will find your own name, and all the scheduled patient will be here. So you can click into the name to review their chart.
Okay, and then if I need to initiate a power plan from there.
Yep, I can show that to you. Okay.
And then what would we do if we wanted to say, oh, can you organize a follow-up appointment with somebody else?
Oh, with like a different provider?
Yeah.
If we're gone for a week or something.
Okay.
Is that what you mean, Pierre? Like if they need to be seen a week that we're away?
No, it's more if it's really a long-term follow-up patient and you're just away for a week, and it'd be fine if you saw them next week.
Well, I'm just wondering, would it be easier if you write it on a piece of paper, give it to Cherry, and then she can just modify the appointment?
Well, I'm thinking I'm going to do
Would
this, and
that
I
work,
might not be
Michael?
physically in the office.
I'm just trying to understand the scenario.
Yeah.
So this patient is a patient who's sort of been re-referred or is called in for a one-off appointment, and or how is that patient ended up on the schedule in the first place? Because Tommy's come in from the already scheduled appointments to this place.
Yeah, I guess there might be a bunch of reasons that they got referred. The ultimate would be referred to the wrong clinic, but I don't think that would happen because
yeah,
very smooth. But if it's somebody that we think could be rescheduled and follow somebody else.
Okay, so
or we're going to
an
be
example
away,
would be, say, an inpatient who was referred directly to Dr. Gee, but should have been referred to Dr. Potter.
Yeah.
Is that kind of the example?
Something like that.
Yeah, so if that happens and you see their name on this list and it's under your name, we would definitely think that it'd be probably like either to connect verbally with the clerk to change the name on the appointment or move it to a different date for the other physician, or you can use message centered for the clinic pool to let the clerk's group know that that needs to be moved. And so, yeah, that would be the two desired methods of communicating to the clerk at that point, I guess, if you weren't near them.
Yeah. So how would that work going through the sending a message to message center?
Sure. So if you're opening the chart, Tommy, if you open a patient chart here, once you're in a patient chart and then you go to the communicate button at the top, and then you would hit a message, and then in here, in the to button, it would be the pool. So we would trying to think of the quickest way. So you can hit the binoculars there, Tommy, and we can find the pool name.
Just do ortho
And then
or something.
if it's pool, and then if you search by the name ortho, what was his? Yeah, so then it would be admin and then you add them and hit OK here. So then the patient's names and context here, their encounters attached to this message, and say, please rebook with Dr. Potter, or whatever you need to write in the free text. And then you can send this, and then the pool will get that notification that something's off with this. Yeah. Or not rebook, please move all bookings to Dr. Potter, whatever the communication needs to be in here, I guess that's clear for the clerk.
Like that option.
Yeah, this comes standard with every clinic, and your pools do exist, so we did create those.
No, the part where Dr. Potter sees all my patients.
Yeah, no. Don't let
You weren't
Pierre don't let Pierre autofill that.
Okay. Oh yeah.
Yeah,
the
what goes
auto
around
text.
comes around. So I could end up with the same next week. Sorry. Yeah, better not go there.
Okay. So we're okay with this.
Okay, that's clear. That's good.
Okay, good. Okay. Yeah, so our plan is to have all the power plans favorite for each pathway. So you have different pathways here. So for the most part, you just need to kind of click order, inbox, and sign, hopefully. But before we get to the power plan, I just want to double check something here. We spoke about the ultrasound for DVT.
Yeah.
Let's go back to here. Is this what you will order for DVT? Like
Well, it's
vein
just one leg. It wouldn't be
It wouldn't be
bilateral.
bilateral. Okay.
No.
So it would be ultrasound, lower extremity, and vein Doppler, right or left. And then we got one for upper as well.
Upper would be really rare. So if
Oh,
you're gonna spend the text, do it on lower extremity right now.
Okay. So we will have these put into the urgent ultrasound quick order.
And then the CT, I see you have as well.
And which one?
The
CT folder in the urgent box there, Tommy. Just two
Oh,
above the
and the
ultrasound.
CT one?
Yeah.
Yeah.
So these are enterprise. These are seen by every orthopedic physician. So we're the lower extremity venous Doppler left and right. When we add this here, everyone will see it in the ortho position across the enterprise.
They'll thank us for it.
Sorry. So what do you want in the CT?
I think that works because we can pick from a list there, right?
Yes.
Jeff, if we wanted that, does that make sense?
Do you want us to add anything else?
No, this works.
No?
And if
Okay.
something needs to be more detailed to me, then I would just click on orders and go do what I need to do.
Okay. All right. So we'll just add those ultrasound ones. Okay, perfect.
And then just going back to you said that we had a power plan for somebody.
DVT?
That's the one. Those are the two: ultrasound, extremity.
Oh,
lower extremity.
sorry, I'm looking at the ultrasound box in the imaging and diagnostics urgent.
Yes,
And
they haven't added it yet, but they're gonna move.
Oh, I see. Okay.
Yeah.
That are there into that.
And are you okay with the order sentence here? I just put in query DVT. Do you want anything else? That's fine.
Good.
Okay.
Urgent. You put urgent query DVT.
Urgent query DVT. Okay.
But is there an urgency that we can put with that order, or?
Yes, there is.
I think there is, right? So.
Yeah. It's stat already. I think default is stat.
Oh, okay. Well, that's fine.
Yeah. Okay. All right. So for your power plan.
So, can you show Dr. Potter this? We were just talking before we got on the line. Oh no, you were, it's perfect there. That if you wanted to cancel, Jeff, if you wanted to cancel some weeks, like for that case, if you wanted to, that was
okay. Let me do that.
Came before.
Let me do that again. I will do this. Okay.
If over here, if you wanted to cancel some of the weeks or some of the visits, you could do it right there, and then for that person, it would just go. And then you could also do this as a just save.
Yeah. So for some of your pathways, if you only require like 4 visits and not 9 visits, you can do that and save it as a favorite. You can do that. Yeah. Okay. So this is just the same power plan Sherry showed you this morning.
Yeah, Dr. Potter wasn't there, so I think if we can just quickly go through, just take a minute. So Jeff, there are two things that are on our op one and our non-op one. Like the operative one, the remove sutures, remove staples will be checked in. What we added from text in there in the special instructions is that we ask our colleagues to contact MD if any concerns with infection, wound healing, or swelling, or something like that. That'll be the same for
This is this is labeled as a distal radius non-op.
Yeah.
This is just like this is just a sample.
Yeah. You see they weren't checked. And Tommy just checked them now. So, but at default they weren't checked.
So we'll be using this in creating favorites.
Correct. I think
is that the idea?
Yeah, we're
They're
happy
all
to
going to
work
look
with
the
you.
same, and we'll create favorites for the.
That's correct. I think from a maintenance perspective, it would be easier to make changes amongst the group if there were favorites that others could copy from you and then customize a little bit more to their liking. And Tommy's name here, the distal radius non-op, is all free text that's added at the time of saving the favorite, so not part of the formal naming convention of the plan.
Yeah, we get so that this sort of set we could save it at the end once you're happy with it. You say, okay, that's how I want to follow my non-op distal radius. But of course, in this case, you're right; those wouldn't be checked in. But I just want to let you know how the types of what we had discussed this morning. Yeah, so for this, it would be wrist that would be checked for the distal radius, and then we don't know if it's right or left. So.
Yeah, so whoops.
And we said that the text for these will be follow-up fracture, right? Or fracture follow-up, that's my name.
Yep, so all these should be defaulted. You don't have to do anything. Yeah, and also here we have our follow-up order. So for example, for this one, the next visit is happening on week 2. So the follow-up order will say in 1 week. If it's happening 1 month from now, you'll say in 1 month. And you'll be pre-configured. And then
so when I just want to say, so this one I'm doing before clinic starts. I'm just selecting these.
Correct, yeah. So I guess for standard patients, you might not even need to go in here to modify because everything will be defaulted. But it's a good idea to review your power plan before you sign, that's for sure.
And then I'm trying to see and eventually we'll get to that. We just did pre-clinic thing, but what I'm doing during the clinic to confirm that the next appointment is when the next appointment is when I'm expecting it to.
Right, yeah. So you just have to confirm that. It would be pre-selected as a default to start with.
Okay, so if I wanted to change it, then I would change it and I would change it in clinic. Otherwise, it just carry on.
Okay, otherwise, just leave it. Yeah.
When the nurse initiates or makes that first visit order set active, that future order then will fire to the clerk to book the next subsequent appointment on the encounter. So that'll happen automatically if you don't change it yourself. The duration will be preset in 1 week based on whatever parameters you set there.
And I'll try to show you that too. Okay, any question? If not, I'm going to order it. Okay. And okay, that's it.
So this person now has their appointments planned at the sequence. Oh, can you show, can you come back to the orders and show Dr. Potter the visit, how that looks like? The various visits that were listed on the left column when you were demonstrating the plastics one this morning, or is that's not built maybe?
Oh, Just okay.
It's
One
sure it's
second.
not built out for your ortho plan, but you can show them the
Oh, yeah, here we go. Yeah.
plastics one if you'd like.
Yeah. So see, Jeff, you were asking, that's another way for you to cancel future clinics would be through here. Because you would, let's say visit one was done or skipped or whatever, and they're coming to visit two, then you could go through that.
But
You could
you said
discontinue.
visit one was set at 1 week, so is it going to be? I mean, we're presumably seeing them when we set that, right? This order form is filled out at their first clinic visit, so I'm not sure how we're seeing them at 1 week if we're doing this at the time of their first visit.
Yeah. So let's say they come at 2 weeks. What do we do with that 1 week appointment?
Or
right.
does
So if you want 2 weeks,
or is it the 1 week, or is the 1 week is the 1 week starting from their first clinic visit? What's the 1 week reference off of it? Is it their first clinic visit?
Yeah.
It's off their first clinic visit, not their OR date, right?
No.
Correct.
No.
So the first clinic visit then has to be specified still either in the referral from the emergency department or the referral from post-op.
That's correct. Or the
Correct,
urgency that you accept when you fill it out on paper tells the
Yeah.
clerk when
Right.
to book that first appointment. That's correct.
Yeah, that's why we have this priority
How do
here.
referrals come from the emergency department or from the, like, this is a bit of an aside, but how do follow-up appointments get set from the operating room?
There's such a
no
thing as a
pathway,
continuing.
really.
We do. There's a continuing care order. Like if I'm orthopedics and I want to send my patient to the outpatient clinic, there is an order called the continuing care order.
So we have to include that. We have to have our post-op order set modified to include that.
You can add it as a favorite to your post-op order set if you want every patient to have it, or you can have someone place it at the time of discharge. I think you have to be on an inpatient location, Tommy. Let me double check.
Oh, okay.
Yeah.
I think Marina and the CMLs are doing this already, Jeff.
But the daycare patients, Pierre, the
daycare,
distal radius fractures, etc.
Yeah.
We're gonna have to figure out.
Do you see those patients?
Sorry, that was a bit of a side. So then,
I think it's important, Jeff, because there's an existing power plan that we haven't discussed this flow of outpatient day surgery patients. So we have a power plan that's ortho post-op daycare or post-op ambulatory or something. Where we would need to have this continuing care order added, please, Michael.
I think we can, so that those power plans are shared across other physician groups. We can work with you to fix your favorites and share it with your team, or we can put forward a request to have it done. But it would affect everyone using the day surgery post-op multi-phase.
This is the same problem that we ran into, Pierre, when we were going live over at the hospital with our order sets, is because they're shared order sets. We were very limited in the changes that we could make because they're used across the facilities. So,
but there could be a continuing care order that's not checked.
Not checked. I think that the group would accept it as a request if it's a frequent requirement. It's just something we have to put through the group.
I think it would be useful for us to just have that in our favorites, because otherwise it's going to get missed for sure. Otherwise the residents have to be using our favorite every time. They're not going to know to do that necessarily. I see people. I think the easiest way is if it's baked into the order set, and it's not like something large that other sites would have to wade through.
No, I don't think it's
they could include their own clinics in a drop down.
Okay. Jennifer pointed out that this is only available on inpatients. So is it possible for you to look up our order set, Tommy, for in the provider quick orders, like provider view quick orders?
I might have a test patient open that can show this. Just a moment.
Oh, sure. Yeah, go ahead, Michael.
Just because I don't want to disrupt his. Yeah.
Do you have ortho?
Just a moment. I'm going to steal it from you, Tommy.
Okay, go ahead.
Can you see my screen okay?
Mm-hmm.
So there are only 3 continuing care follow-up orders available in the system, one for UBC and one for VGH that would be applicable to you guys. If I choose the VGH order, then it would be in here. The default is post-discharge, yes or no. If it's a day surgery patient, it's kind of irrelevant because it's the same day, but we could have that set. And then scheduling priority would be something they could choose. You would technically, we want it within 2 weeks of discharge within post-op day surgery. Is that correct?
Yeah, 2 to 3 weeks.
And then VGH orthotrauma now lives in here as the location. And then, so you could type anything there and the special instructions could be filled out as needed. If this is being filled out by a resident and they know who the attending is, they could put the person of relevance here as needed. So this would then flow to the clerk to book and they would build a pre-recurring for them with this.
So 2 questions. So could we add this order, continuing care follow-up, to our, well, all our order sets really? And
to the day surgery ones is the request,
the day
right?
surgery, yeah. Now the second question is, can it be added to day surgery? Because from what Jennifer said, it sounded like an inpatient. So,
But Pierre, there's an admission for all of our patients. Like there's a daycare, like an encounter admission for all of our patients, right? Because if we see the same order sets for post-op care, regardless of whether or not we've like assigned them a bed upstairs.
Correct.
Post-op.
Sorry, that's a semantic piece of decision. You're right. A day surgery encounter is considered an inpatient encounter from an HIM perspective. So this would be applicable to the day surgery encounter patients.
Right. So if you go to our ortho day surgery post-op order set, there's a
it's under trauma post-op.
Oh, I meant plastics.
Ortho,
apologies.
No, it's ortho day surgery post-operative.
Yeah, I'm in a
space day surgery post-op.
I'm set to the plastics provider position. Sorry, even though I'm just going to set this here, orthopedic workflow. Save. I just have to close the chart and reopen it. Apologies. It's just the test environment settings. Okay, so it should reopen to ortho. Patient quick orders. Post-operative. Arthroplasty, ortho.
no, it's
ortho
day
surgery.
surgery. This one?
Yeah.
ortho day surgery post-operative. Yeah.
Yeah. So this is the only day surgery post-operative power plan we see, right? That you use frequently that we need to request.
Yeah.
Okay.
Yeah.
Yeah. So that's what we would be asking to add to.
And then if you look at I want to see what our order options are in here for that discharge.
Sure. So I've selected the second phase of care for surgical day care, not for PACU.
And
at
it's
the
on top,
bottom,
it's on top. It's at the beginning.
discharge.
Patient. So the default is discharge patient instruction. That's okay. There's a follow-up there. Yeah, patient follow-up appointment.
So it could just be added to the drop down. I guess not. It has to be a separate order.
It's just a different order type, so we would just request for it to be included somewhere in here. Yeah, but this is where it would live, correct?
So this changes the dynamic from the nurses in recovery room, PCU, giving the patient the information with the phone number to call, to now our clerks receiving a request for a follow-up appointment. Is that right? Or?
I mean, technically, like if the requirement is still to have, you could update this. So if you needed this to say, have an option in here to say, patient should receive a phone call with their outpatient appointment at VGH. Like it's a bit.
I think if we can add this to the order set and it's happening automatically, then I think that's for the best for the clerks and the patients, right? Because right now what we are relying on is so analog. That I don't think it's reliable. But if it's in the order sets, I mean, there needs to be multiple redundancies built in. So patients still need to be told to call if they don't have if they don't hear. And we've got the prescription pads, Pierre, that have the clinic phone number on it.
Yeah, we could add the follow-up order here and still look at like saving a favorite that has more information about like the clinic should call, but you can call them if you don't hear a call. It's up to you guys, whatever.
Yeah, I
but
mean,
we
I
would
think
probably,
the continuing care order, adding the continuing care order to what we're doing already would be
Yeah.
a plus.
okay, yep. I'll stop sharing. We did deviate from the clinic, but it does answer some other questions.
No, this is great. I'm glad this came up, actually. Thanks, Jeff.
Similarly, while Tommy's taking back his screen share, the request around a message center notification for patients that present to emergency after being discharged, that is going to surgery working group, and we don't foresee that there will be any pushback to build that for VA. There might be a request to expand it beyond Vancouver acute locations, but that really impact you guys, and we'll take that through the other groups as needed, or the other physician leads for the other sites.
And then
So-
visits to the emergency room, is that going to be anybody on Cerner or just VA?
Correct.
visits to the emergency room?
Any emergency location across the Cerner enterprise.
That's great. Except for our patients who are in Fraser Health or the North. But yeah.
Okay. So I think that was the standard workflow, and then you were wondering about with if you have to reschedule appointments, how is that going to work?
Yeah, please.
So how do you do it currently? What is your current workflow for that kind of thing?
Well, I usually try to accept them and refuse them.
Okay.
But if it looks like it's somebody who needs to have a longer term discussion than just once in a lifetime visit with me, then I try to reschedule them. And then I just put a note, can you please reschedule this long-term patient for Dr. Potter is back in 5 days.
So I think you can use the same method that we talk about, like the message center, and then you can just send it to Cherry so she can rebook it. Would that work?
Yeah, I think so.
Mhm.
Just have to
Okay.
remember how to do it. Oh, it's communicate, or it's
Yep. So power chart, communicate, and message.
and communicate can be. Is it just about the patient file or about the document that's on my screen? So when I communicate, is it understood that I'm talking about the referral that was just sent to me, for example? Do you see what I'm saying?
It's about the encounter that you're sitting on when you send it.
Okay.
So if it's a referral encounter at the time of sending it, it'll show as a referral. If it's a pre-recurring because you're just wanting to move the appointment or get it rescheduled, it'll tell the clerk that when they opened it as well.
Great. Next is date of clinic visit. So when patient arrives, click register and check in the patient, assign location as required, and send the patient to X-ray as required.
And then we added them this morning that the clerk
Yes.
will be checking if the splint needs to be removed for X-ray.
I will show that. Okay. Sorry, I just need to find my clerk one. Okay, perfect. Okay, so this is the one. Okay, so when the patient arrives, the clerk would check in via the scheduling book. Sorry, let me just pull this down here. Okay, so I'm going to use, which patient am I going to use? I'm going to use this one. Okay. So I'll right click on the patient and then I'll go to action. I'll check in. Okay, so I will go okay. Register outpatient. I'll go through my check-in process. Okay. So I want to update my encounter to an active encounter. And I'll just update all these mandatory fields. Yes. Okay, non-accident related, say no. And then I'll complete, and this is when we print all those registration labels. Okay, now the patient's check in, the return screen. So on the ambulatory organizer, which I'll go back, I'll just refresh. Oh, I don't even need to refresh. It says patient check-in. So at this point, Cherry can update the patient location, or you can just mark it up on a piece of paper. You don't have to use the ambulatory organizer to do that. And to check whether a patient needs an X-ray or whether there are any special instructions, so Cherry will go to Requisition Manager, and she would just set up a filter. She can save a filter. She can have VGH ortho trauma today, VGH ortho trauma any day. So I think this one is today. So you'll show all the requisition from today. So you just need to set the date, filter by the location. Once it's set, that's it. And to see whether there is special instructions, you would just click into the requisition title. If there's a special instruction to remove a cast or a splint, it would say here. And
That's a lot of steps.
she does have to go into Requisition Manager to find out. And also the check-in process does involve a few clicks, yes.
Yeah, I mean, right now it's on top of the chart because that's what it says on the X-ray rec to remove the cast before. That's how I do that.
I don't know if there's a faster way than going into the actual chart.
No, I think the only other alternative is to have the requisitions printed for all the patients who are arriving that morning. So they can look at the schedule and print them if they choose to, but that seems like also a lot of work. I'm not sure what the better of the two solutions is.
Is there a report that can be printed? Is there on the MI side a report that can be printed that's got special instructions? You know what I mean? Like it would be one page where all the patients would show up on one page or something.
Like a slate?
Yeah, like a yeah. Like a,
Yeah, they can print a slate. But those are scheduled.
The slate wouldn't show the contents of the X-ray order because the X-ray order is kind of a floating future order. It's not pinned to today and now. It's not linked to the outpatient appointment in any way, which is why they collect here for someone to manage if they need to.
So how would radiology know? Can radiology know a day ahead of time the volume for the next day?
Not really. No, radiology is kind of victim to if someone puts a requested date for when they think the patient should show up. Let's see how there's two different columns here in Tommy's view. That's only if a physician fills that date out at the time of signing the requisition, which I think is almost never, to be honest. So I think X-ray just kind of takes the volume as it comes. They know how many total pending exams sit in the system at any one moment, but they don't know how many are coming tomorrow or Tuesday. I don't think. Am I right?
So there's no advantage of if we're filling in the charts like whatever a week before, or they wouldn't see that the number of charts we've gone through, the number of X-rays we've pre-ordered ahead of time.
They would know how many are sitting in the queue, but they wouldn't know how many are exactly for Monday, I guess is the point.
Okay.
Yeah.
I was trying to see if from there they actually produced a bunch of reports. Number of clicks that it represents from.
Yeah, I mean, technically, if it's not done at the time of patient check-in, someone could just sort through these and put a comment stating cast or splint off in that comment column. The clerk can add comments here as needed. As sort of just like maintenance of the list as opposed to checking it when the patient appears in front of them. So they could pop into anything that's an X-ray order and filter by only X-ray orders when looking at this list. We could try and generate a report, but it would probably show every pending X-ray order at the location as well. So that would be not necessarily very useful either, I think, as a risk.
I don't know if there's a way for us to put that in our requisition.
Sorry, was there a question? Sorry, I didn't catch it.
No, I was trying to see without not knowing the system.
Oh,
I could just let you know what our usual process is. Unless we establish some kind of system.
You could potentially, the only other place where you could document needing a splint off before X-ray might be in, if it's a continuing care order, you can have text included in that order in the special instruction so that it shows on the scheduler, on the ambulatory organizer. That is a potential option for making sure that there's some line of communication about that first appointment, post-surgical appointment, but it would only work for the continuing care orders because otherwise it would be a favorite on the power plan level, which you could also include actually for any subsequent appointment, but it wouldn't catch the first one.
okay. I think what Cherry might have to do is to have the scheduling book open on one monitor and then the requisition manager on the other monitor, and then she can just kind of go through it. So it'll be quicker. Okay. Back to our slides. So the provider would place any ad hoc orders as needed, perform assessment treatment, and sign a requisition for patient to bring home as needed and complete documentation.
And then the piece about the follow-up appointment. So I just finished seeing a patient. I need to change their follow-up appointment.
Right. Okay. So let's do that. Okay. So my orders. Oh, let me just. I'm just gonna initiate this one. Okay. All right. So you can, if you want to change this to like 2 weeks, you can just right click, modify, and then change it to 2 weeks over here and sign again. And then this would,
good.
yeah, and then that would send a message to Cherry here. I'm just going to see. Yep, so you'll say 2 weeks. And Cherry can just book that.
Well, that looks good.
Okay. And for your requisition, so you can, oops, can place your requisition in Cerner.
Can I just, so right now we're doing that for people basically as we're seeing them and as they're leaving clinic.
Okay,
I would see myself doing the follow-up visit input after the clinic. Like I would see myself sitting down and going through the patients, doing the dictation and putting the follow-up visit in.
Mhm.
Rather than doing that on the go. That shouldn't affect workflow then, right? Because
yeah,
then they just go into the queue for a follow-up visit at 2 weeks.
yes.
And they will be contacted for the follow-up appointment. So whether I do that while they're in clinic or after the clinic, it's not going to affect Sherry's workflow for setting up their follow-up time, right?
Well, it's
No,
one
it's
more
right now
phone
she's
call, because
setting
they
their
could just,
follow-up.
yeah, go ahead.
Yeah, because right now they're going to the front desk with a slip of paper and Sherry's booking them in and telling them when their clinic visit is.
Mhm. If
So
you're,
if
if you keep the follow-up order in the phase that's started by the nurse when the patient arrives, then it'll fire the moment that they sign and initiate the order. If you update it
Okay.
later and if it's already been completed, then it will show as completed, and then you would have to message Cherry to change it if she's already used the request. If you didn't want it to fire right when the nurse initiated the orders for that day, you could have it deselected, and then at the end of the day, just pop in, select it, and hit fire for the next duration you want it to. It's just chicken or the egg, I guess, is the desire.
But potentially if we don't want to change it, we just let it run the whole
Yeah.
sequence of recurring. Sherry's going to get it. We don't have to get into the chart. But if we do want to change from the usual, it's probably better for us to do it right there in the clinic, because then the patient can go to the front desk and get their new appointment. Otherwise, it's going to be an extra phone call, at least one anyways.
Yeah, to change the appointment later, that's correct. Yeah, if they do it on their way out of the clinic, then the order would be need to be up to date.
But hopefully, like the default, we've already pre-planned their 1 week, 2 weeks, 3 weeks, all this business. And then we don't have to touch that. It's just
It's only if it's an outlier and you need to change it, correct? Yeah.
Yeah.
Does that work, Jeff, then?
Yeah, I mean, I think so. I'm just not sure that I'm going to get to it all the time at the time of. Be also nice if I don't know if we're going to get to the point where we could do this by email.
Yeah, well, right now there'll be
Uh,
something that's
was-
set. So when they go to the desk, that's the appointment they'll get, unless you change it.
Yeah. Okay.
Okay.
And then changing it will depend. If you change it during the clinic, they'll know. Then if you change it after the clinic, they'll know later, but it involves an additional contacting piece. Which maybe Sherry can fill in here, but it might take more than one phone call sometimes to reach a patient.
Okay. So for ordering outpatient requisition, you will go to here. Okay. So you will go to your outpatient quick orders, and then there are some quick orders that you can select from. So for example, we're gonna say C-reactive protein. You click
And are
that.
these in a certain order, like the most frequent
Um,
orders, or what? How does the order set?
Are they alphabetical? Let me see. No, they're not alphabetical.
I think it's
I'm not
frequency of use is how the quick orders team configures these. So the most commonly
Okay.
used is the CBC group green electrolytes right at the top.
In the whole hospital or for us?
By specialty, I guess. And if there's a disparate, like something terribly out of order here, then let us know and we can request the reorder.
Well, essentially, to me, CBC and C-reactive proteins.
Yeah, I see C-reactive protein at the bottom. Yeah, I don't know how, if you want like that moved higher up.
For now, until
For now.
it gets bumped off. But this is a test environment, right? So
Yeah.
it might not reflect
It should reflect the live environment. These aren't something that the user can change. I can double check in the live environment though.
Yeah, and these would just go to the requisition manager, and Cherry can just print them off and give it to the patient.
Which I'm in the live environment. What's the, is it? It's quick orders? Oh, but that'll be different from inpatient to outpatient or
Yeah,
not?
it's
That's
the
right.
outpatient
Yeah,
one.
they are
yes.
different. Yeah.
Okay. Because we don't have any nursing or PT here, I'm not going to go through their documentation. So lastly, before patient leaves, the clerk will book follow-up appointment like we just showed you, for any requisition as required from the requisition manager. And then if there is an end of treatment order, Chair would discharge the encounter.
So would you mind showing Dr. Potter what we discussed this morning in our orders and in our part plan that, I mean, I guess you use the plastics one that showed the discharge piece. So if we have recurring appointments, the last one will have discharge, but if you need to discharge the patient before you can do that.
Oh yeah, if you want to discharge the patient prior, you can just add a end of treatment order. And for end of treatment.
Oh, I thought there was one already.
Tommy didn't order the last visit 4
Yeah.
in this test one, so it would have been in visit 4, but we don't have it. So
Oh,
if you're
okay.
saving a favorite, yeah, then and you don't want visits 4 through 9, you need to have the this added to your favorite.
Yes, and so normally it will only appear at the very last visit.
And then could I pick it up from there and just order it now? Or let's
It
say
wouldn't
visit.
be in your visit 1 though.
No.
Or 2, 3, 4. It would be in your visit, I don't know, visit 9 maybe.
Yeah. And can I?
Yeah, but you
Yeah,
you
but
do
you
what
can
Tommy's
add your
doing here.
face and do a favor. Yes, you can do that.
Well, why don't we just build one into each one of them? That way, if we need to discharge the person at visit.
So build the end of treatment into visit 2 and on.
Yeah.
Or even visit 1.
Sure, visit 1.
Visit 1? Okay, everything.
I thought we had a single phase. Or not.
But it won't be
I
checked. It won't be checked, right?
Yeah.
It won't be checked, no.
Exactly.
The last visit
Okay.
will be checked.
Yeah.
Okay.
Yeah. Okay.
Okay, let me just let Sherry know. Yeah, and this will just go into the PM office, the recurring discharge work list. So it will show up here. And then Cherry just need to discharge those patients from the work list. And that's pretty much the entire patient journey. Any question, concern, anything else?
The only other thing that we haven't, the only other thing we haven't shown Dr. Potter is within a visit, if there's the orthopedic plastic procedure, like the cast changes and things like that. Just, yeah, orthopedic technician. We just show him that, what that looks like.
Like, yeah, I think we're going to add a few more items into the cast splint dropdown.
This should all also show up by frequency as opposed to.
Yeah, again, the short list of sentences that you'd like made available for you guys. If there's if when we take those requirements forward, if you want them built as down arrows as opposed to clicking into the list, we can do that. We just need that requirement from the group, from you two.
I mean, short arm cast is going to be the our winner. Now there's, yeah, I did send you, what I sent you this morning were the splints.
Splint, yeah.
In the Excel document, but I didn't send you cast, which most common is short arm cast.
Short arm cast is the most
SA.
common. This one.
Yeah.
Okay. I think this is alphabetical.
It looks like it.
Yeah,
Yeah,
so it's
that-
easier to search, I guess.
Yeah, normally it's alphabetical for these fields.
Okay.
And what's
But
the
when we
last
give
one if
our-
you click them?
Oh, go ahead. Sorry.
Tommy, can you show that under walking boot, after walking boot as well?
A walking boot. Okay.
After that, no, after it, but like below walking boot. Looks like
The
the
selection is
walking
below
boot.
it.
Wrist.
wrist. Yeah, so.
So the two
short
most
arm
common
cast,
ones that
wrist,
we're
yeah.
using are the two most common ones that we're using are the two at the bottom.
And short arm cast.
Yeah, if we had a top 5 for the most common ones you use, we could build them as single sentences, so you're not entering the. Is there any ones with drop downs, Tommy, and that you can show as an example?
Don't know if I have a drop down.
I think this because that one was already ordered. I think.
Yeah, let me try another one.
I should send you an updated cast and splint because I just done splints this morning.
Oh, sorry. And ortho. Okay. So here we have a splint new, splint follow up.
Yeah. So
That's all
where
we
it says, where it says split new, splint follow up, if we chose splint new and then all the splints and then follow up,
Rest.
splint follow up, right? And then cast new, and then those would also be available in a sentence format, a pre-filled sentence in this drop down. So if we have those, we can give them to Sherelle and make them available to you guys for quicker ordering.
Or if we just went modify on this, it would show us the bigger screen. But you're saying we can okay, that's where you would put the top 5, I guess.
Yeah, top 5 in this drop down arrow, but if you want to modify it and go in and pick something that's totally outside your normal, you could do that is the hope.
So is this ours? Do we have ownership of this order set that you're showing us right now?
Yeah, this is your prototype. This is the one we were working through this morning.
So does this reason for exam splint new versus splint follow up? I don't see that as being important. But if you had reason for exam splint walking boot, reason for exam splint short arm cast, reason for exam splint wrist brace, then that would be useful.
Yeah, everything
I'm not
bolded
sure what
were
the value
required.
of the new versus follow up is.
It's to satisfy the mandatory field in the order. So we
But the
did
drop
get
down.
the drop down would still show that we've selected that in the favorite.
Oh,
but
I
we
see.
can
So splint new, splint follow up. So are we able to put that in without specifying what splint?
technically the device details are not a required field. But we were
perfect.
But it'd be nice to put it ahead of time, right?
If you desired to and you were wanting to try and let the ortho know.
I mean, I don't know. I'd rather, if I could just do splint new, splint follow up, I'm happy with that. And then you can just verbally tell them what you need.
Yeah, I think we talked with Lizette this morning about that, and I don't.
that it wouldn't be Lizette, that would be the nurses.
Oh, right. Okay, for the routine ones that where there's no variation in the type, then I don't think there's objection from the group, especially if it's clear
The only
based
other
on the
thing is
clinical.
that, and I guess that could be verbal as well as specifying, degrees of setting for the hinge or specifying if they need wedges or not for the walking boot. That could be verbal.
Yeah. Again, if it's not a mandatory field here, if it was something you told the nurse, they could write that output in their documentation of the boot that they gave to the patient. But it's available here if you want to for special instructions.
I mean, the top 5. Would be, I'm just going to copy paste them into not in that order, but would be this.
Okay. Thank you.
And of the top 5, they look like they're all splint.
Yeah,
And one
there's one
cast.
that's a cast,
Everything's a splint except for cast. Okay.
Thank you for that little extra tour, Tommy.
Okay, no problem. Let's see here.
So can I just say, if we have for the 5 drop-down options, splint new, splint follow-up, walking boot, wrist, short arm, if those are the 5 options for drop-down, then the problem is if the drop-down just has our 5 most common, if it's not one of those most common, then you're gonna have to go searching for it. But if you have splint new, splint follow-up, and then the 3 most common, which I think is going to, then if it's something other than the 3 most common, you could just pick splint new, splint follow-up, and then give a verbal direction.
Yeah,
But
we can
what's the difference?
have,
Why do we have new and follow-up?
I don't know.
What do they
I don't
mean?
know why.
But we don't need to keep those. We can change that, right?
you don't have to use it. We can just have only splint new selected
If
or
it just
split.
says, yeah, if it just says whatever, I mean, just if it just says splint.
Mhm.
Why don't we just have in the, in that menu on top where you have that one there, why not that drop down have our 5 most common there?
I think the
Get
reason
rid
for
of the new
exam
and follow-up.
is linked to like an appointment type at other sites. So that's why they're showing as new and follow up, where they're actually scheduling a tech off of this request.
Let's
So
build it for us. Let's build it for us.
I think if we can keep it so that we can make both, like like you say, Dr. Potter, a generic answer like splint new or splint follow up, and then those other ones with the type of splint as quick drop downs. That would be the quickest way to satisfy all groups. Because we can't remove the content for the purpose of them being able to schedule the exam. It's like the referral to order. It's the same. It's seen by everyone the same way. We can't hide sections of the order, unfortunately.
But the people who got the pick first get their pick.
Well, it's just that they schedule. Like if you had the requirement to schedule a technician and they didn't, we would be adding that field to this order for everyone to see, and so it would impact them the same way that it's impacting us right now. It's just so happened that we're after them and they needed to schedule a tech.
So are we going to do split new for the first 4 and then like a cast new for the last one? Is that what we're doing?
No, we should put as many choices as we can of our favorites in whichever appointment. This whole new and follow-up means absolutely nothing. So,
Yeah, it doesn't. I agree that it means nothing to you guys. We have Irvin on the call. I don't know if we can add another option here that's just splint or cast without new or follow-up attached. Irvin?
And the reason for exam field?
Yeah, because they don't schedule. They're not. This isn't going to a request list for this clinic.
Since you mentioned that it's being used enterprise-wide, I think any changes would require an EDD to this field.
Or just approval from the SMEs that are using them, like one of the two.
Right, or the approvers.
Yeah. We wouldn't necessarily need to go to working group, but you potentially could add splint here, but it would not be schedulable. So they would know not to select it if they chose it.
As long as I think it's clear that it's different from the other splints responses there.
We might be able to.
Okay, I don't like, just to be clear, I don't really care what it says, splint new, splint follow-up. On the options that said cast splint type, we like to have our 5 most common options.
Oh yeah, we're already putting those forward. Sorry, we are already putting those forward, and then we'll include those in this top 5 drop down, but also generic splint new, splint follow-up in the top 5 drop down.
Yeah, it's just, I'm sorry if I'm sounding frustrated, it's because I am. It's just that this is constantly what happens, and we work together. This is constantly what's happening. Whenever there's an option to make it faster, we do not have access to that because we're the last hospital that's joined this party.
Okay. I think we kind of went through everything. Let me just open up my clinic key here. Okay, sorry about that. Okay. I think we went through everything, clinic information, roles. We got our printer and fax number sorted. We got our encounter sorted. We're gonna use referral and recurring for the most part, and outpatient for those one-off. And now gonna have clinic flags. Schedule an appointment book. Location is gonna say VGH ortho trauma. Document type in the work QM is gonna say referral package. We're not gonna have any message center pools. For the recurring work list for Cherry, we're gonna have our referral encounter work list, recurrent discharge work list, and then a bunch of appointment types and orders. Ambulatory organizer, we have our rooms already built. And nursing, they are going to use just the order profile for most of their documentation. And provided documentation, I think we are just going to use our free text document until a template developed. For nursing, they would like to use the power form. PT, they also like to use the power form.
But we would have the opportunity to have some templates and that we could use.
Yeah, if
Okay,
you have anything
so-
existing in your current state, I guess in Cerner, in your already existing, or in a legacy system.
But we don't use Cerner in the current states.
So you're using what are you using right now?
Still dictating.
Dyslexia?
So,
Oh, you're
no,
still verbally dictating just on the phone. Okay, yeah.
Oh, okay.
But if you did have templates in Plexia or in any other private EMR, or if you had them in just in a Word doc, we could take those and import them for you. Just let us know.
Mhm.
So what's
Yep.
the latest date to import those?
You can do it at any time. Tommy and I and the informatics team is available for you guys. So it's not like it's not built in by the design team. It's just it's personalized.
Okay.
And we can add them to our profiles in the live environment, and you can copy them from us and modify them as you need to. So if you just give us the text, we can do that in advance.
Yep. And then I confirm that the MOA has access to the provider compensation report for billing. And that is it. Oh, I think this morning you were asking about having a referral form in FormFast. So if you have that, you can send it our way, and then we can see what's available. If not, we can have HIM scan into FormFast.
Well, yeah, they are available. I can
Oh, are they available
look
in
at my
FormFast
favorite.
already?
Yeah. I made them favorites already
Oh, perfect. Okay.
as we were looking. So I don't know how or when I communicate that to you.
No, if it's already there, we don't need to do anything. But if there's something that you want in there that isn't already in FormFast, then we need a hard copy for that to submit.
Oh, okay. It's not like you're creating a quick link within Cerner to get me there.
No, they're still hard copy print documents.
Yeah, you still have to go into FormFast and print those yourself.
The upside being that the patient's encounter location and demographics will already print on that form to save some time, but not a lot.
No, Jeff, that was referring to community care referrals for physio or dressing, like wound care. And there was another one I can't remember. Yeah, I think those were the main things.
And that is it. So we finished all our sessions. The only ones left is the order set. And the next time we meet might be our adoption workshop where we teach the staff in person.
And then is there anything else we need to do with the Excel sheet that you had sent before?
I think since we've gone to a single multi-phase design, we can hold on to it. And if you guys want to use it to think about how you want to structure your personalized favorites, then that is useful. If you find it useful, we can update it with the details we've gained from you guys so far around what we're adding to the technician services order, what orders we've removed from scope. I don't know if that sounds like something that would be useful for us to clean up the template so that you could think about how you want to structure those favorites with us, or if we meet with you to set those favorites, we could just walk through each kind of conceptual idea and enter them together.
I think we might have to set up an entire afternoon to go over those favorites with you.
Yeah, it wouldn't be a formalized design session because it's just
No.
setting those favorites. So it would just be whenever you need to meet with Tommy or I, or the CIS is on our team.
Okay, thanks.
Yeah, and if there's anything further, any questions or any input, please let us know now. It's easier to make changes while we still have the resources versus post go live. Any
Well,
other
so far today,
questions
the only
from-
stumbling blocks is related to the orthopedic technician orders. So
Yeah.
finding a way to make that simpler and reflecting what our needs are as opposed to a pediatric orthopedic clinic would be the again.
Yep, and we'll work on that.
Yeah, any requirements that are updated on that, we can correspond with you guys over email, and that will actually come up in our next order set session as well. So we won't consider that closed as far as the contents of that order today.
Hi, Cheryl. Can I just ask Dr. Gee, Dr. Potter, when do you think you could have that list of X-rays to
I just
me?
sent it to Dr. Potter, but he was in clinic this morning, so I
Perfect.
probably can have a look, and I wanted to make sure that it's finalized before we move it forward.
Okay, perfect. Thank you.
Okay, any last calls? If not, we'll end the meeting early. Thank you so much, everybody.
Thanks. Okay, bye.
Thank you. Take care. Bye.
Thanks.
Thanks, Tommy.
Thanks.